so excited to welcome everyone to our actually first chat like this, our Women in Medicine virtual panel. And what's so exciting is, I don't know if you all knew this or know this, this is Women in Medicine Month. So wishing all of you all out there a happy Women in Medicine Month. And I thought it would be fitting for us to have a conversation about being a woman in medicine. And so we are all from Rochester Regional Health at different stages in our careers. And the exciting part of this conversation is that it'll allow us to be able to talk about different aspects of being a woman in medicine, from being someone who's in training all the way to someone who's been a practicing physician. So what we will first do is we will go ahead and get started with introductions. My name is Dr. Amber Robbins. I'm a family doctor and faculty member at Batavia Primary Care at UMMC, Rochester Regional Health. And I'm also the Director for Diversity, Equity, and Inclusion for Rochester Regional Health's Graduate Medical Education Office. So I will pass it over to Dr. Hines. I'll let you go ahead and introduce yourself, and then we'll kind of go around.
Hi, I'm Dr. Samantha Hines. I'm a third-year psychiatry resident at Rochester General Hospital. I'm also an American Psychiatric Association Fellow in Community Diversity.
Welcome, welcome. I'm going by how I see people. Dr. Blonsky.
I'm Dr. Christine Blonsky. I am the primary care, I'm a family physician by training. I did a primary care sports medicine fellowship, and so now I practice full-time primary care sports medicine for Rochester Regional Health. I have a blend of a practice between non-operative orthopedics, working in Rochester Regional Health's orthopedic department, doing non-operative orthopedics, and then I am also the head team physician for a local university, Rochester Institute of Technology, and the program director for the primary care sports medicine fellowship training program at Rochester Regional Health.
We'll definitely be talking about the many hats and how to balance those. All right, very good. Dr. Loomis.
Hi, I'm Liz Loomis. I'm the program director for family medicine with Rochester Regional Health, just out in Batavia. So I practice with Dr. Robbins. And I would consider myself kind of mid-career, just from perspective of where we're all at.
Welcome, welcome. Glad to have you. And last but certainly not least, Dr. Artiaz. And I'm hoping I said that right.
You did. So hi, everyone. I'm Maciel. I'm one of the third-year medicine residents at Unity Hospital. I'm also one of the associate chief residents and the head of wellness in my hospital as well. I mean, my residency program. And I would like to say that I'm early career still.
Very good. So you'll see that we have a vast array of knowledge here and people who are wearing lots of hats. So that really is fitting for the conversation that we have. As women in medicine, a lot of us do wear many hats. So a lot of times the question is, how do you manage that? How do you manage your wellness? How do you balance? And how do you remain sane when doing all of these things? So let's start there. What do you do to be able to wear all the hats and still be an impactful physician? And you can unmute yourself. It's just a conversation. We're just going to make it really casual.
So for me, I am lucky in kind of the job that I have, that even though I wear lots of hats, including probably the most important one I look at as mom to a 6-year-old, being able to have my job be that I can work family things into my job is helpful. It has its own risk reward, I suppose, but as the head team physician at a university, I don't take call, but I do cover games. And so my nights and weekends are often occupied with hockey games, soccer games, lacrosse games, wrestling matches. And what is nice about, and part of why I chose the specialty that I am in, is because I love sports. I eat, breathe, and live sports. But being on the sideline is a job that doesn't feel like a job. And so it really, the place where I'm employed has given me the flexibility to have my family at those events, because oftentimes it is family fun time. I have a very supportive family who will watch my kid when he's on the sideline, but I will tell you, every single athlete knows who he is and has heard him roar many a time. So for me, it's about kind of balancing work and life, but balancing it by being able to blend it, because I love my job so much that it doesn't feel like work. Make no mistake, I do have time away. I have vacation time and partners that cover for me to have dedicated family time as well. But I have strived to shape my career to allow all of that blending together, so that it doesn't feel like work, even though I'm putting in a ton of hours.
And I think there's an aspect of how things change over time. Like right when I was out of residency, I had a ton of loans. I didn't necessarily have the opportunity, like I was moonlighting in addition to like a regular job. And that was really hard, but that was where I was at in my life, was needing to say yes to more opportunities for those reasons. But things do change. And I think understanding that your career is long, and then being able to continually adjust to different circumstances is really important. So like Dr. Blonsky, I have a daughter who's a little older. So we went from daycare that would take her anytime to school that has school holidays, and things that you have to kind of cover. And so I think it's about recognizing where you're at in your life. What do you need to say yes to? What do you have options of saying no to? What works for you and your family and your goals in your life, and then constantly reevaluating that and renegotiating it with your family, renegotiating it with work, and being willing to like recognize, okay, this did work for me and now it doesn't. So what do I need to do to change that? And I think that's one of the things that I've seen over these past years is being flexible and being open to change.
Yeah, I love that. And both of you all really kind of were able to like really point out being able to be flexible. Yet we know in residency, flexibility can be really hard to come by, right? So how do you all balance? For Dr. Hines and Dr. Ortiz.
So I think something important that Dr. Loomis said is that sometimes you have to learn to say no as well. We try to take as many opportunities as we can. We tend to say yes a lot because, so many opportunities that we can take advantage or learn or make ourselves, more known. But at the same time, sometimes we have to say no, and we have to understand that our priority is training, and that nothing can, become in the middle between you and training. You cannot be too tired to learn. You cannot be too tired to learn from your patients. I think from in training, in residency, that's one of the most important things that we can learn is when I can say yes, when I can say no, and how many hats is too much. Because sometimes we can get involved in too many projects at the same time that can be very, very hard for our mental health.
I wanted to add a little bit of a different perspective in terms of like not just having like residency, having a lot of responsibility in residency, but I find that throughout my education, medical school and residency, one of the biggest thing is like the pressure from my extended family. So I have to take care of my mom, my dad, my sister, my nieces. So that like learning boundaries with that is very, very helpful. And sometimes your family does not understand what it takes to go through a day-to-day life as a doctor. Like they're really excited and really proud, but they don't understand how much work it is. So it's kind of like constantly being patient with them and explaining to them like, hey, this is what I need to do. This is when I need to take time to myself. This is when I need to take time to study. This is when I need to take time to deal with my patients, and just setting up different times that you can deal with like family struggles. Like, okay, I'm going to talk to you on Sunday, like I promise, like something like that, where I set aside time to like more so compartmentalize, because like it can become overwhelming when like your family puts all the pressure and burden on you.
Yeah, that can be definitely very, very difficult. And trying to be able to let them know what that actually lived experience is like, is super hard. Because the only way that you know it a lot of times is by talking to other women or other physicians who go through and deal with the different pressures. So what pressures do you all feel like women in medicine have in comparison to our other colleagues? What things do we have to really deal with? I know you were saying, Dr. Hines, some things with extended family, but are there certain things, particularly for women, that you all have heard or have experienced yourselves?
I know for me in particular that one of the things that I struggle with is confidence. And I feel like compared to like my male colleague, where they're not as afraid to like get an answer wrong in front of the attending, I have to like double check, like, am I absolutely right? Research the answer before I speak up. So it's difficult to like find my voice, because I feel as if I'm letting everyone down if I get an answer wrong. So that little bit of that pressure I put on myself. So that's some of the difference that I've noticed.
One thing I've noticed, that not just me personally, but just observing trainees over the years, and the difference between women in medicine and men in medicine, is kind of this perspective. I think it's really important. You know, we've said, multiple people now have said, you have to set boundaries. I think that there are that are maybe less recognized boundaries by ancillary staff. I think that in general there is this idea of, well, she's nice, she's not going to yell at me, she's going to help me. And your women in general are viewed as the motherly, more approachable type, and the path of least resistance, per se. And so there is this kind of general, I would say, generalization that occurs like in medicine from every level of expectations that women are going to be easier and more helpful, and we can take on more burdens and won't complain about it. And that's a real challenge. And for me, especially like working in an orthopedic department, which is historically, nationally, medically very male dominated, the approach to patient care, the approach to patients, you know, there is really a dichotomy, but does there have to be? And I think that that's a challenge that I think we all deal with and have to learn to negotiate. But I think that it's really important. I can't stress enough the idea of setting boundaries and being able to say, hey, no, the expectation for everyone in this department is this. So you shouldn't be always coming to me with the difficult patients because I'm good at it. You know, we all need to, you know, work cohesively as a team, and share the burden of straightforward and difficult patients across a patient panel. And I think that that is one thing that I have observed as a woman in medicine, and just generally with other women in medicine. The biggest complaint or concern has been, yeah, well, they always say that I'm the nice one, so they ask me, you know. And so I caution other women to kind of be wary of that and make sure that you are setting boundaries early so that you don't fall into that trap of being recognized as always the nice one, because it is a recipe for burnout.
And Dr. Blonsky, there are studies that back up some of what you're saying that show that female physicians spend more time with their patients in their encounters. And then they also receive more like portal messages, phone calls, like unequivocally that is the truth. Now, they also show that we have better outcomes in some areas than our male counterparts. And I think the lesson is, yes, you need to set your boundaries, but that also some of these things that as women in medicine we're really great at, our male colleagues need to learn from as well. And that they need to be kind and they need to be willing to take the challenging patients and being willing to spend more time with them and being open to communication. Now, that probably will not happen until our reimbursement structure is different and values outcomes in a different way, as opposed to volume of procedures and encounters. But I will say that even though we are spending more of this time, we are also seeing better outcomes. Boundaries still, yes.
I will piggyback one last thing on that. As an educator, and I'm sure you feel this way too, Liz, like I feel like it's my pay it forward to educate our male counterparts that are young on why it is that we do things the way we do them, spend more time with patients, do more education. I preach to residents day after day that our primary job as physicians, regardless of your specialty, is education. And unfortunately, education takes time. There's no way around that. I work in a very kind of picture heavy, treat the picture, not the patient subspecialty, but I have a passion for education because I say it to the people I train every single day. Treat the patient, not the picture. That's the difference between seeing an orthopedic surgeon and someone such as myself. My practice is excessively busy, and patients come see me because they appreciate that time. I mean, I don't know how many times we hear something different.
And you all mentioned burnout. So that's the thing, right? A lot of times we give this excellent care to our patients, and over time you may have burnout, you may have emotional fatigue. How do you prevent those things from happening while still trying to give the best care possible?
I think like how I like to think about it is I have to be the best version of myself to be able to take care of my patients. Because if I'm burned out, I'm not going to be able to take care of them. If I'm feeling burned out, I'm not going to be as empathetic as I usually am when I'm not tired. So we have to prioritize our wellness, take time for ourselves. We're not being selfish if we take some hours to ourselves to take, to be alone, to watch a silly movie, to eat a proper meal without having to run around. And I think that's a very important mindset, just to think that, I have to take care of myself, because if I'm not doing well myself, there's no way that I'm going to be a good doctor. I'm going to be taking care well of my patients and even my family as well. If I'm tired, my spouse is going to get the backsplash of me being tired and being mean at home.
I'm laughing because I agree with it. Dr. Hines, you are our psychiatry expert. What advice would you give?
I think what would be most helpful, especially dealing with like difficult patients, I find that as a psychiatry resident, like I see very, very tough cases, like patients that are very hopeless, and it's hard not to take some of that home with you. And then you feel like, now that I'm like in my third year where it's mostly outpatient, so now I feel primarily responsible for some of those patients if they don't show up, if all this stuff. So you have a lot of things weighing on your mind. So it's reminding yourself that you're doing the best that you can, and the best that you can is showing up every day for your patients. And even if you're scared, if you're worried, like, there's not much else you can do but being there for your patients. And also like trying to compartmentalize that, because I used to take things home with me all the time, just really stressed about like, how can I help with this patient? Like, they just got the diagnosis, they have stressors at home, like everything possible that I could think of. And I have to like make sure that I don't bring that home with me. Make sure that I'm taking care of myself, make sure I take that break for myself. And then finding activities outside of work. Like, we are prone to like identify or have our identity tied to being a physician, but that's not just what we are. And I found what's most helpful is not just to say that I'm a doctor practicing medicine, and just not be like, I'm a doctor, so that everything is tied into my identity as a doctor, and then you don't have much room for anything outside of that. So I try to make sure that I prioritize other things that are important to me, my family, or like activities that I like to do. Like, I like to go out, I like to go dancing and all that stuff. And now I have trained myself not to feel guilty about it. Like, yes, I'm going to be worried about the patients tomorrow, but today I'm going to have fun and I'm going to take care of myself.
Yeah, and I haven't heard that. So I am a doctor practicing medicine instead of saying I am a doctor. I love that. And you all have mentioned in different ways the culture of medicine. Dr. Hines, you mentioned the concern of confidence that you had, and saying certain things because you were afraid that you would be wrong. Dr. Blonsky, you mentioned about how education and teaching, teaching our male colleagues. With there being more women in medicine, right? We know that our medical school classes are starting to dominate with women in medicine. How do you all feel the culture of medicine is currently, and what hopes do you have for that culture to possibly change for the better? Was that too deep?
I know.
Okay.
I mean, I think I'm very encouraged kind of with the more focus on work-life balance that's coming through, and that is across gender, across kind of cultural lines. Is that I think a lot more of our medical students, a lot more of our residents are really looking for ways from the very beginning to start out with a better balance. And I mean, certainly someone I'm responsible for people. Like, I'm the person that says, yes, you are a resident, you have to do these certain jobs so that you can graduate. But I think, seeing people looking for the part-time positions or the positions that include time for activities that bring energy instead of take it, that include different roles. I think we're seeing a lot more requests for that. And I think it's harder for the system to sometimes change when they're used to like, oh, a new doctor is a full-time doctor, and this is what a full-time doctor job looks like. But I think that they are going to have to start to come up with these ideas as we have more people requesting jobs that look different from what they have traditionally looked like. And so I'm pretty hopeful that we'll see some of these shifts and it's not always about less hours worked, that you need a certain amount of sleep and food and exercise. Absolutely. But sometimes what you really need is a part of your job that just builds energy. And so I think that flexibility in what the job looks like, I think we're seeing more of those requests, and I think we'll have to see systems answering that.
Think what I'm most excited about now that we have more medical students that are female, and overall residents as well. We're almost half. I think we're like 48% of the residency force are women. Is having a different perspective as well in leadership. I think most of the leadership in medicines are males, and I'm hopeful that as more women are interested in medicine and they are being accepted in medical school, with time, leadership will be more diverse and we will have a different perspective in medical issues, and that will change patient outcomes as well in guidelines and reimbursement and all of that. That is super important.
I love that. I think more women in leadership roles. You know, I'm inspired to see that as the climate of medicine changes. For me, I continue to be in a very kind of white male dominated subspecialty, and so I am excited as the scales tip that maybe we'll start to break down some of those walls and have more women in this particular subspecialty. I mean, we are seeing it across the board in the American Society of Sports Medicine, that applications are up. And for me, as a program director of a training program, I certainly do look at that to try and elevate more women to equalize that imbalance that we see. And so that is what I am hopeful for the future in my particular subspecialty, really tipping that scale from 90-10 to something a little bit more equitable, and having more women colleagues to go to and work with and commiserate with, if you will, throughout. But definitely it's going to start with leadership. And I think the inspiration of young people moving through education and being able to express what they are looking for, but also being able to demonstrate, hey, I can do things as well as my male counterparts, is exciting.
And that's probably, I think you asked a question earlier about how the culture in medicine is, and now I want to piggyback in this because I think the culture in medicine is changing for better. Overall, in the past, we did not used to talk about our families at work. Now it's something that is more accepted even in interviews for residency and fellowship. One of the questions that people ask is usually, how family friendly is this program? I have kids and are planning to become pregnant. How is this going to affect my position, and how is this going to affect my life overall? Because some of the things that sometimes are challenging for us as women is that when you are interested, for example, in a surgical position, you're interested in becoming an orthopedic, people used to say, oh, hours are killing, you are not going to have a family. Now the fact that we're talking more about families and acknowledging that, residency is the prime time to have kids, to have a family, is something that is helping a lot as well to change the culture overall, that women can be in medicine and we can do whatever we can do because we can balance all of these different hats.
And I think the key is making sure that you are in a program or interviewing for a program, like you were saying, that is family friendly. So if you have those things in mind, make sure that you see the program already has people with kids, or they have the flexibility to work with you and not cause any extra stress. So we have a question from Dr. Hook. She's asking, has anyone been in a leadership role in where you felt you were treated differently than your colleagues? And if so, was it better or worse?
I would say all of us as physicians are in leadership roles. So just by, the fact that you're a physician, you are a leader. And so my example of this isn't in my current program director role, but like coming straight out into my first job, finding out that some of the male colleagues hired after me had a higher salary with less experience, or got loan repayment when I was told that wasn't an option. I think was the very first time. And I was assured that it wasn't based on gender, but I mean, it was also one female person compared to 3 male colleagues. So I would say that felt still very much like something, and maybe it was how I was socialized in negotiating, and I maybe didn't do as hard of a job as they did, and so maybe it came out from those reasons. But yeah, I would say right off the bat, I think my career was marked very clearly by differences in who I was compared to some of my other colleagues. And I threatened to leave, and I interviewed, and then they gave me what I wanted. So I stayed at least for a while longer.
Thanks for that, Liz. I think that you're right. Women physician across the boards will probably, if you ask 100 of them, 90 of them will have similar stories of this person got hired at the base rate of XYZ, even though there is this like little you're not supposed to share salary information and all of this kind of stuff. But I think it happens too often, this idea of this dichotomy. As far as like administration treating me differently in my leadership role, I have been lucky. I have honestly had two main jobs since I finished my fellowship training. Both were split in education and clinical practice, and both I was highly recruited and supported by the administration to drive change and be that leader from a female perspective in a department that lacked females for what I gave and what I did. And it didn't take long for patients and practice managers to kind of recognize exactly what you mentioned. The studies show, outcome data is better. I can count too many stories of patients coming in for a second opinion with a non-surgeon such as myself for what they've been told is we can't help you, when really all they needed was a little bit of listening and education to figure out what really was the issue and then turned it around. And so I think I've been lucky as far as leadership. I haven't had that dichotomy, and in fact, I've had support right up along from administration, and I try to pay that forward with where I'm at, and so that's how I've taken that and my leadership role in trying to be more involved.
So I wanted to add from the resident perspective, obviously I don't really have a leadership position per se, but as a resident, as Dr. Loomis said, you do function as a leader in your role. And I find that I'm treated very differently from my male colleagues, in that the male colleagues in my program are automatically treated as the leader of the team, or they're automatically respected for their opinions. Whereas I feel as if I have to come in and I have to prove myself, as opposed to automatically giving that respect as being the physician. And as the treatment team leader on like the inpatient unit, it's very difficult, like managing nurses and social workers and everyone if they don't see you as a leader. So when you try to assert yourself, then they see it as automatically being rude. And if you observe your male colleagues having the same conversations with the team, they acknowledge them, they appreciate them, and there's nothing wrong with how they talk to them. So I find it very, very difficult, like in terms of like trying to make sure that I'm respected. And I feel like it's very unfair to have to fight for that instead of like having that bestowed on you as with my male colleagues.
I agree. I mean, my experience is hearing this story from so many women in training and women physicians is this is the same story time and again. And I think that, us taking these roles and taking on leadership roles in order to inspire change in younger people to say, hey, these are the boundaries. This is, and calling things out. And make no mistake, I would not say I've not met with any adversity in my very male dominated subspecialty. There has been points where I have had to say, well, look, there are 4 of us that are all the same on paper. 2 are female, 2 are male, and this is how we're assigning it out. And so not being afraid as a female to call it out, to say, why is this different? Hey, let's take a look at this. And if it means you have to reach out to HR where you're at to have that background, I encourage people to do that. And you should have the support of your administration, your program directors or colleagues or clinical directors if you're in practice along the way. You need to find allies in this. I think that one thing that I have found, though, is in medicine, in some ways, our own gender toxicity. There are some women that discriminate in favor of men as well. And so trying to find those allies and kind of break down those barriers to say, hey, why is it that we're doing that? We do it to ourselves. It's not just males discriminating against males. And so nursing staff, access associates, things like that, it kind of goes through. And I think taking the time to educate and point out certain inconsistencies is the only way that we're going to be able to make headway to change things for the better and change this climate.
I personally think, and have seen myself in different, years. As a first year, I felt the same way as Samantha, that maybe my voice is not heard the same as my male counterparts. But with time, I realized that sometimes, if I'm talking to other colleagues as well, the difference is not really my gender, it's really my tone. So if I feel confident when I'm talking to my interns, if I feel, if I am talking without doubting, without hesitating, they tend to take me more seriously than if I'm, just trying to be nice. And I think that's something that happened with us, with females. We try to be nice, and we think that if we are being too assertive, we're not being nice, we're being rude, as you said. But sometimes we have to be assertive. We have to be affirmative, especially when you are when we are dealing with that position of a leader. I see it as my position as chief president, I'm a position as leader. I'm not trying to be mean. I'm just trying to make my point of view clearer, because I think that's the difference between us and our male counterparts. They're not trying to be nice. They're just trying to go to the point. And sometimes we put too much makeup on stuff and we are trying to make it too pretty when it doesn't have to be. We just have to be honest.
It sounds like it's more of a language that you have to learn. And so I'm curious to understand how you all have learned that language. Was it something that you saw through role modeling? Was it something that you developed over time? Because as residents and medical students, we're trained to kind of do what we're told, right? But not necessarily having a voice to be able to advocate for yourself or to be more assertive. So where was it, or who was it that you may have been mentored by or viewed to help you be able to speak out on these topics?
Yeah, I think mentor is a key part there. So identifying mentors throughout your career is very important. Looking at people who occupy roles, if not specific jobs that you're interested in, leadership or education or research. So identifying those mentors and meeting with them regularly. I think, when you're in a specific mentorship relationship with someone, you should be meeting with them with a certain frequency to review issues and topics and help work towards your goals. So I think that is super key. I think most organizations are going to like most professional organizations are going to have things that reach out specifically around leadership development, around women in medicine, around DEI initiatives, and I would take advantage of those. You know, I know the ones in family medicine really well, but I know they exist across specialties, to try to really like attend those meetings, attend those seminars. Like this is where, you know, saying yes to some things might actually give you energy, because then you're in a group of people who are thinking about them. One of like the best sessions that I ever went to at a seminar was around women negotiating around contracts. And you heard my own story where my own personal background led me to feel like I had done a really terrible job. And so going to this session, like after having had that experience and feeling a lot more confident in you know, what kind of skills are needed and what kind of approach is needed, I think can be helpful. So finding other people is a big part of that.
Yes, negotiating is key. Most women do not negotiate their contracts. They we're known to take what is on the table because that's being gracious, I guess. But there is definitely some room to learn from negotiation really throughout your career, because there's always room to negotiate. If they don't negotiate, then we got a problem. All right. What other role models or mentors? Where did you all learn the language of being an assertive woman in medicine? Actually, being a boss in medicine, let's just say that.
I think it's a lot of, you know, taking experience, you find what type of language worked for you and how you feel that you're more listened to when you're using those type of words. And also learning about everyone. You learned about the females attendings, you learn about the males attending, you take stuff that you like from absolutely everyone and you create your own style.
I would say for me, my biggest role model was my mom. She was a physician also. She came from the Philippines where she went to medical school, and she came here to the States and trained here as an OBGYN, again, in a very male-dominated field. Back when she moved here, she had kids when she was a bit older because of having to go through residency. And so, like for me, my inspiration and my leadership style started in the home, and I got to see it every day, the answer, the calls, the all of those things. But she inspired me, and then certainly, as Liz indicated, that just identifying mentors throughout training. Once you get to that point, what are other doctors that want to do things that you want to do, or do you learn? You know, you have these mandatory rotations that you have to do in your subspecialty, and you're not going to be like everybody in the program. So you take pieces of what you like and what you don't like. We all had those attendings that we worked with that we said, oh my gosh, I am never going to treat patients like that. And then the others that we are so inspired by, as I wish I could be just like her, right? And so really thinking about that, your life, your training, it's all a journey. But for me, the leadership style started at home as a child, and I had the privilege of growing up with one of the best role models there is.
Okay. I thought Dr. Hines. Yeah. So there's a lot to take in. I'm just thinking about the person who inspired me. It was actually someone who I was in medical school, who was my advisory dean, who talked to me about my faces and the different faces that I make and how I speak through my, actually you can see, I speak through my face. So trying to hone that in and being able to say certain things in certain ways that may still come across as being more gentle, yet being assertive at the same time. So it's a practice. It really is. And it changes as you get further and further through training and as an attending. It changes in the environments that you're in. From academic medicine to community medicine, those are different type of ways you communicate. So it's an ongoing thing. So I'm kind of stalling to see if anyone else wanted to ask some questions. If you have questions, feel free to put it in the Q&A. We're happy to answer the questions, and we will, as we're waiting, let's see, any other questions? Because I might just jump into our last question, because I can't think of anything else to stall with.
So sorry, my family's trying to get in the door. I'm gonna go get them.
Oh, okay. Fine. So I wanted to also mention something, and Dr. Hines, you kind of gave a clue to this. There's something called imposter syndrome that a lot of women in medicine actually have. So I'm not sure if you all have heard about it, but imposter syndrome basically is when you feel as if you're in a position, but you feel like it's you're a fraud, that you got there just because, I don't know, you get slipped in the crack and you got in there, but it's not something that you necessarily deserve or something that you feel as if you should be able to portray. And so women in medicine are known to have a lot of imposter syndrome. And so a lot of the confidence or having to build confidence is more so of getting outside of having that imposter syndrome. So I always like to point that out, because I didn't know what that was until I was in medical school. But recognizing exactly what it is, it helps us, just like when we're diagnosing things in the clinic or in the hospital, understanding what it is and that diagnosis helps us to figure out the treatments for it. So I want to pivot to our last question. What advice or what treatment would you say would be helpful for those who are watching, for women in medicine, for future women in medicine as they go along their journey?
I think
Dr. Robbins, I'm so sorry. My family returned from soccer. Could you just repeat real quick what the question is? And I'll let Dr. Robbins speak.
I know. So what advice would you give to women in medicine? There you go.
I think there's a few things. I think one, being mindful. I think that that's one thing that we all need to do a bit better. And I think that some of this kind of imposter syndrome comes through when we're not mindful enough of being confident of what we've done, what our goals are, what our goals for our patients, for our family, for those around us. And so being organized, being prepared, and then also just engaging, be you. I think that maintain who you are through all of this. Don't try and be something you're not in order to be successful, because successful looks different for every person. What you may think is successful may not fit what I think is successful for me, and it may not work. And so you have to kind of be really good at looking at yourself, looking where you're at, and seeing that place from where you are and how you want to get there. And there are lots of different paths, but being mindful of how to do that and identifying the right resources to support you in that goal, I think is really important.
I think be objective as well. With imposter syndrome, I might have something by luck, but all the other steps, all of them are just the result of a lot of effort that we put time on and that we dedicate ourselves. And I love to remind myself of that. If I'm here, it's because I went through med school, I took steps, I'm doing in residency, I did first year, second year, third year, and just being mindful of all of those tiny milestones that we achieve at all the time, but that they require a lot of effort and a lot of sacrifice. And that's something that I did. So I have to keep reminding myself of all the things that I have achieved, even when I don't feel like I should be here. If I'm here, it's because I deserve to be here. And this is what I'm doing.
I would say when you have the means, get a housekeeper and a plow service. And if you don't like to do it yourself, a person to mow your lawn. Like, we have enough jobs that at some point in time, you should be able to outsource some of them. And I think that is one of the best pieces of advice that I ever got. And has made a huge difference. So in all seriousness, think about those things in your life that you don't have to do yourself. And if you don't want to do them yourself, find a way to get someone else to do them.
I think I have two important advice, like don't suffer in silence and also ask for feedback. So what I mean by don't suffer in silence is that imposter syndrome is real, and the panelists have talked about that, but finding people who share that experience, especially other women, if you're a person of color, other people who are a person of color, and try to find people that you can call or text or reach out to. And if you can't find anyone, there's in programs, they do have like mental health services that you can find someone to call. So a lot of us suffer in silence, like dealing with depression and anxiety because of all the stress that comes with medical training that we definitely do not talk enough about. And I feel like people are more likely recognizing that. And something that is important to ask on your interviews, if you're interviewing for residency or you're interviewing for jobs, is how they manage those, like how do they manage someone in crisis, right? Have they ever experienced anyone in crisis? Because you don't know, like you could experience a complete loss. You could have difficulties through your training or in your job. And you want to make sure that you have that security and that support. And then asking for feedback. So when you're like, oh, I'm making this mistake, I don't know what to do, then you think like, oh, I should just go home and study more, or I should do this more. But what is most helpful is recognizing people who are where you want to be. And if they're in a position where they can observe your work and how you interact with patients, how you write your notes, or whichever format they are able to observe you, ask them for feedback. It's hard to like hear negative things about ourselves, but that's how you grow. And don't be afraid to like, okay, I'm going to cry a little bit when they tell me I did this wrong, but I'm going to fix it, because if you don't know, you can't fix it.
Excellent advice. Thank you all so much. And speaking of feedback, we would love feedback on our virtual panel. So feel free to reach out to us at Rochester Regional if you're in the system, or if you even want to reach out to us on our Instagram for Rochester Regional Graduate Medical Education, because I believe that this panel was the bomb. These are conversations that a lot of times we have in the back rooms, in the back corner, that sometimes don't necessarily come up. But I appreciate all the panelists for being with us tonight. Thank you so much for those who have joined us and who are joining us on the replay. And our hope is that we can bring more of this to you. So thank you again, everyone, and happy Women in Medicine Month.